I'm Pam Valentine. I'm the CEO for Alberta Innovates Health Solutions. And on behalf of our board of directors and staff, I'd like to say welcome. And on behalf of our partner for the Health Policy Speaker Series, the Institute of Health Economics, I think represented by Doug Gilpin this morning, one of the board members from IHE, I'm really delighted to be able to be here to introduce our guests for today. Dr. Makoto Suematsu is the president of the Japan Agency for Medical Research and Development, or AMED. Dr. Suematsu and his two colleagues accompanying him, Dr. Seiya, professor in the Institute of Advanced Medical Research at Keio University, and Dr. Mashiko Noda, managing director of the Department of International Affairs at AMED. Dr. Suematsu is visiting Alberta as a guest of AIHS, the University of Alberta, the University of Calgary, and will be exploring potential partnerships with us. His organization, AMED, is a very recent arrival to the global ranks of major research funding, development, and support organizations, having been created in April of this year with a budget of over $1 million Canadian. AMED is described as a one-stop service for research expenses in Japan, as it is a consolidation of budgets earmarked for research from several different government ministries. I think we can learn many lessons from the thinking that inspired AMED to establish an integrated environment of research and development, from basic science to the application of outcomes. Dr. Suematsu is an exemplary leader in improving medicine through research and development. He has both an MD and a PhD and pursued postdoctoral studies in gastroenterology, microvascular surgery, and biomedical engineering. His research areas are broad, encompassing biology, physiology, and metabolomics. Before his appointment as president of AMED, he was the dean of Keio University's School of Medicine. Please give a warm Alberta welcome to Dr. Suematsu.
Pamela, ladies and gentlemen, first of all, I would like to greatly thank for all the Canadian friends to give me such a wonderful opportunity to speak about our agency. As Pamela kindly introduced, our funding agency was born, unfortunately, in April Fool this year. So we have only 7 months until now, but I really would like to show you how we can start up and how we should solve the problems. There are many, many problems, so I would like to concentrate on several serious problems and how we can overcome, I would like to show. So once upon a time, I can say, the Japanese funding system was so complicated. Actually, it continued until the end of March. And as you know, there are 3 different ministries. That is a Ministry of Economy, the red one, and the Ministry of Education, blue one, and the Ministry of Health and Welfare, that is yellow. The reason why the length is different among 3 ministries are following. That is the amount of the budget for the medical research. And in total, it gives us the $1 billion US per year, particularly in this fiscal year. The problem is the color is different. There are 3 different kinds of bureaucrats. They never share the same language. They speak Japanese. But there are 3 different Japanese, and they can never understand to each other. That is a real problem. But Prime Minister Abe decided to reorganize this funding agency systems in the country into just one system, that is AMED. That is a big challenge for us. Unfortunately, there are actually many, many unfortunate things, but The size of the budget, which is all coming from the tax, which is about 4% of the whole NIH budget. It's small. But this budget is still large for all Japanese scientists. And also, it is really interesting to know we have many officers, 330 at present moment. And these 300 officers are coming from 3 different ministries according to the ratio of 1:5:4. That is the length of the color bars. So that, in other words, so they never think about a function, they never think about a structure, they just decided the number of the officers to be sent to AMED according to the size of the budget. That is another terrible thing. But fortunately, I have a great help from many universities. We have 80 different medical schools and many pharmaceutical companies, universities. And they kindly send us the few students or the postdoctoral students who are very excellent under the officers. So now all these postdoctoral students are fighting with officers. But this fighting is not real fighting, I believe. Such structure stimulates the communication using the different languages. Even in they all speak Japanese. But this type of overcoming the difference of the language is really necessary to stimulate the medical R&D, I believe. What is the aim of AMED? That is to fast track the medical research and R&D that directly benefit people, not only by extending the lifespan, but also by improving the quality of life, not only for Japanese people, but also for the other countries' people too. So now you can see here the very tiresome organization scheme. I was so much disappointed to see this organization map. It was almost 1 year ago, right after receiving the appointment document from the ministry. So because if you rotate this figure into the clockwise rotation, you can see the vertically divided organization. It doesn't work. And I said, why you prepare the horizontally divided figure to the one of the chief officer who I trust right now, who is from the Ministry of Education, and prepare this figure? And his answer is the following. So I don't like to hear the people saying it is vertically divided. And that's why he prepared the horizontally divided one. That makes no sense. Actually, I experienced a very tough interview from the foreign press people, and one of them kindly published the article in Science at the beginning of May. It says that Japan's NIH started with modest funding but high ambition. I'm a bit pity by seeing the modest funding, but I'm very keen to stimulate the Japanese medical R&D with a very small funding with a high ambition. But more importantly, if you carefully see this article, I am so surprised to see, maybe you know, many years ago, there is a word, Balkanization. And Japanese Balkanization causes a very terrible thing many years ago. As you know, at the beginning of the century, it was a human genome project which figured out how the DNA is sequenced. in the human. At that time, the Ministry of Education spent huge money to deliver the next generation sequencer all over Japan. And at that time, the Ministry of Education was expecting to see the use of these machines in hospital too. However, unfortunately, there was no negotiation between the Ministry of Education and the Ministry of Health and Welfare, and as a result of this, all of these NGS never used in hospitals. So accordingly, the project produced a huge number of the very good paper, which including GBAS story from Japan, many excellent papers. But can you imagine how the patient can be cared by eating these papers? It is impossible. So we really need something different in terms of the systems organization. That's why we are thinking about. And the Japanese government and the AMED decided it was the end of July this year. We were 3 months after the birth. The government decided to rearrange the system of genomic medicine in order to provide overcome directly to the patient. It never happened in Japan, actually. So if we start up this all over the different field of medicine, so AMED will be terminated because of the limitation of the budget. We have no, if you provide the NGS to the all scientists, both basic and clinical, it is almost impossible to manage to do. So in that sense, we decided to start up from the 2 different fields. One is a cancer research. You can see vertically the cancer research. And another one is a rare and intractable disease research division. We have a 9 division, the 7 vertical division, and the 2 division for funding. One is a genome research infrastructure. Another one is an industrial academic collaboration, which mission is to develop the medical device. They are 9 main projects of our country. But we just concentrate on rare diseases. I would like to show what is going on right now. Maybe some of the participants have ever seen this article. This is a syndrome without a name, which is a patient advocacy group for the patients whose diagnosis is not yet done. So actually, these patients, there is a disease, but nobody can make an exact diagnosis. Even when they are going to the university hospital or national center, no diagnosis. We have many, many diseases which most of the physicians unknown. So they are going back and forth, traveling many, many times, and going to the hospital, big hospital, but no answer. And finally, they have nothing to do, and one and only way to go is to visit the home doctor who is taking care from the birth to the present. That actually happened in many, many countries, I believe. And in Japan, we decided to launch the very small project that is called the Initiative for Rare and Undiagnosed Diseases. And such project is going to be started up in the United States or all other countries I know. But I would like to show you, we have almost 45 years history of the rare disease research, which is supported by the law. And some of them are supported by the national healthcare systems, but a very small fraction. And the government recognizes almost 1,000 diseases, but only maybe 10% can be covered with national health care. And all other rest of the patients are supported not by the national health care, but by the other systems such as research money also. That is a real problem. So, and another problem is how to care those who are undiagnosed. We need the genomics knowledge. But there is a problem actually between the home doctor and the core hospital or university hospital. We have a very big gap. So we have nothing to do to exchange the information about the genome or phenotype of patients. Usually the home doctor understands what is going on in terms of phenotype or symptoms. And researchers in RIKEN, for example, RIKEN is one of the biggest basic science institute, or other universities, they know very much about the genomic science, but they never understand to each other. So that's why the funding produce continuously many good, excellent paper, and they never provided a platform to apply to the front line of the medicine. So we decided to make up some circuit system which start from the patient. It is the clockwise rotation, if you can see. The patient goes to the home doctor, and the AMED try to provide all these information of the new project to the home doctors and regional core hospitals and also the university hospitals. And we started up this project from this August in the Tokyo district, where the many populations are there. And we would like to extend this system all over Japan within 4 years, and spending money. And also the RIKEN or other university who are very interested in the genome science per se, we utilize these people and all the infrastructure in order to make up diagnostic activities. And also, we are asking the help by many co-medicals who are responsible for how to explain the result directly to the patients. And it is working right now in a very small district of the Tokyo metropolitan right now. But I am very keen to spread all over Japan like this within 4 years. And there are many problems, but maybe you know the Japanese national healthcare system is very homogeneous and cover the most of the patients. Actually, I can say the 100%. That is a very specific. Of course, we have a very serious problem of for supporting the finance. But I believe we need to continue this flat and equal opportunity system. So based on this system, we would like to open up the ILAD system from this year. So how we can make up our single gene diseases? Single gene diseases, I can say there might be at least 7,000 different diseases. And right now, we know only 5,000 in terms of the contents of the articles published previously. And the Japanese healthcare system or other countries' healthcare system, such as UK, just covering the 1,000 or less. So we need to continue this activity to make up very clear role and function of each gene, how to induce the diseases. We have we have no 100% answer for that. We need to continue to do it. And this is one of the examples showing the result of the genome analysis by the next generation sequencer. This is one of the examples. And as you can see at the top of the vertical pyramid, you can see almost 100,000 variants. Variant means some of the gene disorder candidate. And nobody knows which one is responsible for producing diseases. So we need to reduce the number of variant candidate by using some sieve, molecular sieve, such as the sieve indicating the normal Japanese variant. There is a variant which never produces diseases. So we need to eliminate one by one. And finally, we can go maybe 10 or 20 or 40 or something. At that time, next generation sequencer has nothing to do to specify one gene responsible for diseases. In that case, we really need the communication between different physicians or different home doctors or different doctors in university hospital. By so doing, we can check. That is called case matching. In case of case matching, not only genome information, but also the very detailed symptoms or phenotypes which can be seen from the outside. This is very important. So another problem in Japan is the global communication, as you know. There is a very interesting system which was established many years ago, that is an International Rare Disease Research Consortium, which is called IRDIRC. But the Japanese government never joined in this program. That is a pity. I don't know the reason why, but I can imagine that there is no bureaucrat who can speak English, maybe. And that they are rotating almost every 2 years. So nobody is responsible for taking care of this type of things. And who is the victim for that system? Absolutely, the victim is a patient. So we need to join, first of all, and we did it at the end of July, and trying to participate in a discussion about the data sharing for patients, first of all. This is very difficult for most of the researchers. I used to be a researcher until the end of March, I know that. Once they can get the good data, they never open up. We always close these data before publication. That is a biological behavior of researchers, as you know. But once we can opening up and sharing the data, at least in this field, the single gene disease community, sharing the data is exclusively important to save the patients. There is no problem. And also, we are starting up the discussion about a global coding of phenotypes. Why we need this? Because there are many, many different languages. So how we can check the similarity of the phenotype between the two patients or three? So we really need the coding system. And once we can make up a coding and establishing a good database, we can share the data and make a diagnosis very shortly. So, and also, we have a problem of a harmonized IRB. This is very difficult. The IRB, there is a many, thousands of IRD in Japan with a very, very heterogeneous criteria. And once we need the multiple judging by IRB under the different university, and if one university say no, we cannot start up a clinical science, clinical research. So that also induce the suffering the patients. So we really need thinking about a harmonized IRB. This is another challenge. And the as you know, the patient's database for genome is going on right now. You can see this type of a database network. But to tell the truth, the sharing the database is not yet progressively going on, because still there is a biological tendency to close up all of these data in a scientist. We need to open up. We need some incentive system to stimulate the opening the data and the sharing the data in the community. So I don't like to go in detail. This is a guideline for investigating causality of sequence variants in human disease, as I explained. We really need the combination of similar clinical phenotype and the sequence variants in the same, exactly the same gene. Once we can get all of these information, we can make an exact diagnosis. And maybe the pharmaceutical companies are so interested in how single gene induces some diseases, that this type of pathway analysis is really important to understand the very complicated common disease too. So what we are doing right now is the following. You can see here the many flowers, different flowers, and the group of flowers indicate the hospital. And each individual flower indicates the patients. Usually in the field of clinical genetics of medicine, the many scientists try to correct the same disease patients. But right now, it is very important to stimulate the understanding of the global spectrum of different diseases, what is happening on. And we also need a very nice medical education to describe the phenotype very nicely. So, and another very important thing is shortening the length of the barrier among the different hospitals. By so doing, we can hopefully share the data, clinical data, between the different hospitals in order to find out the same patients. This is very important, particularly in the field of rare and undiagnosed disease. So finally, I'd like to say something. The diagnosis is not the end of the outcome. We need to think about a therapeutic intervention. For that purpose, the AMED is just starting up the support by budget for the venture company, which is open not only for the domestic companies, but also for the foreign countries. And we can fill some money in the Death Valley in the orphan drug development. So many years ago, the Ministry of Health and Welfare's officer did this type of things. You can see here the physician as a driver who is tied up totally. They are very busy and many compliance things. So it is very difficult to think about how we can contribute to saving the patients. But the officer says, hurry up, the goal is coming. Go, go, go. But still the officer make a braking to stop the car. That's what's happening in our country. So we need to reform this type of situation. And there is another agency, PMDA, which is very important it's a regulatory science agency, and they shorten the time for checking the quality of each clinical research. And right now, I'm very proud of saying that the PMDA process for judging is the shortest among the world right now. So we would like to collaborate with PMDA to accelerate the medical R&D together. So finally, we have many problems, but how we should correct the data all over the country. That is another problem. Maybe the Canadian people have a very excellent system for that. It's a story of a big science, big clinical sciences. And I would like to introduce the very small example which is actually used in Japan. One is a national clinical database. This picture was taken from the home pages of NCD, and which include almost 95% of all the surgical operation data. And also, the data is used for the evaluation of the specialized license for individual surgeons in Japan. So they automatically need to input the correct data and update the contents. That is one of the tricks to improve the quality of a big database. So, and another important thing is the database was actually used for determining the quality control of individual hospital in Japan. And now the database is starting from the surgery, but right now it covers the multidisciplinary areas of medicine, such as a catheter intervention in a cardiologist or something like that. So it is growing very nicely. And AMED is extending to use the extended NCB we call. The previous NVC just checking all the medical record during just 1 month after the operation. But right now we are going to elongate the period. It might be very useful for evaluating a post-market surveillance for the many medical devices or even for the anti-cancer reagent from the next year. So, and another one is, I would like to just show you the name, JANICE. This is a Japan Nosocomial infection surveillance. This is very important in order to cover the information about the multi-drug resistance bacteria things. So in Japan, most of the big hospital is joining in this database. And as you know, the Japan experienced a very bad experience of the MRSA. This is one of the resistant bacteria. But after collecting these data in JANICE, we can get a very nice position to prevent the multi-drug resistance inside the hospital. But in case of the bacteria in community outside the hospital, we have still some problem in pneumonia bacteria. There are many multi-drug resistance in our country. So if we can compare this type of data all among the different countries, it might be good to think about determination of the health policy. So now we have some trick to stimulate the entry of each hospitals. That is incentive. If you can join the JANICE, we can increase some incentive by revising a policy of rewards. So that's how we can successfully cover the almost 60 or 70,000 percentage of the big hospitals joining in JANICE. But the problem, if you can see the right side, there is no participation in hospitals, the size of which is less than 200 beds. What is real problem is, can you imagine we are super aging country, and most of super aging country is inside the small hospital. And we, at present moment, we have no knowledge about what kind of bacteria is there. And we need to collect these data and sharing with other countries and how we can protect and control these multi-drug resistant bacteria. So you can see here the distribution of the super centenarians in Japan, who is over 110, amazingly. and they are still alive and enjoying drinking sake or the small amount of beefsteak. So we need to collect these data, which is helpful for improving the quality of life. So that's what we are thinking about. Maybe I can stop here to open for discussion. So thank you very much.
Thank you very much. Very interesting presentation, and I'm slowly starting to understand what AMED is all about and where it's going. I just wonder what's your take on support of the health research and basic research in particular, which is an essential part of your scheme. What kind of a budgetary assignments you make in that direction, and about bringing young people into the system and supporting some basic activities that will eventually lead to development of these drugs and helping in particular in those rare diseases?
Very good question. Actually, what is happening in the following, the government and the politicians says, what is your outcome of the research? And how can you contribute to the community? So accordingly, most of the project is designed so that the outcome becomes very clear. But on the other hand, the fraction of the basic research becomes a bit smaller. And immediately after opening up AMED, I asked the many people in our funding agency in UK or NIH. Interestingly, they are still keeping a very nice 55%. They say 55 separately. I'm sure it is very important to support the basic science, at least half. And maybe we can think about another 30% for the translational research. And maybe some of them can be helpful to stimulate the clinical research. Finally, it's a 20% or 25. I think there might be some golden ratio between the three different areas. And right now, the AMED has, I can say, 30% of the basic science. And besides AMED, we have some curiosity-driven budget resource besides AMED. That helps the basic science. But also, even in the AMED, we need to maintain such basic science. And another important thing is, as you know, is how to foster the young investigators. Two things. One is the global collaboration and understanding what is happening in your outside. We would like to help these people to going outside and learning more and recognizing the difference and the diversity of culture. That is very important, and that's why I am here. And another thing is a system, previous domestic system, which should be eliminated. Maybe you know the Darth Vader system, we are calling Darth Vader Star Wars. There is many Darth Vader professor in our country who exert the force to collect all these data. And they never pay attention to the contribution in the outside hospital. And just publish the data and making another force to the other people. It is not good. So maybe I can say, if you can do some nice data sharing, or if you can do some system for fostering young investigators, so that's how we can provide the budget. So that means we need to establish the new way of measures besides the list of publication. I don't know the exact answer for that, and maybe this is a global problem, and that's why I am very happy to have the opportunity, this type of meeting, and sharing the problems and try to solve all these problems. And actually, what we are thinking about from the next fiscal year is the increasing size of the budget for the young investigators. When we can think about a national project, the Darth Vader type professor think about the maintenance of his or her own budget, first of all. And then the rest of the budget should be delivered to the young investigators. But AMED decided to check the size of the budget for the young investigators, first of all. And we need to increase, and actually we are going to increase each individual size of the budget for the young investigators whose age is less than 40. They are the young stars we really need. And I would like to ask these people to experience the foreign countries and doing some nice research work together, and then come back maybe. So we are thinking about this. So I really would like to continue this type of discussion with your team. So how to stimulate these people.
Dr. Suematsu, your gene-based approach has a lot of synergy with the pharmacogenomics revolution.
Oh, yes.
Which has revolutionized cancer therapy. My question for you is, you also mentioned pharmaceutical company partnership in your medical program. What has been the response of the pharmaceutical company to perhaps limiting access to patients based on more appropriate medicines for patients?
Many, many years ago, most of the company are asked by Darth Vader to give some money. And once they deliver the money, the physicians or Darth Vader use these money as they like. It's a consumption. But right now, AMED is promoting the new system. First, we will ask the pharmaceutical companies, or what type of protocol or what kind of protocol for collecting the sample or analyzing the sample in the university is needed for you. And then we can get the list of requests from the pharmaceutical company, and then we can open the, not detail, but we can open up the outline of the request from the pharmaceutical company to the university people, and we ask, if you can follow this type of protocol, we can deliver the money. So we are making up some interface between pharmaceutical company and the university to stimulate the matching fund in this case. If there is any matching, very good. So we can deliver the money by 50%, and the company deliver the another 50%. And that gives $1 million per one project. And we will start up this type of things from this next year. Yeah.
I have a comment and a question. So with respect to encouraging young investigators, I think that is so important. What one organization I work with has also committed to is providing them not just the young investigator, but bridge funding. Because I think the bridge funding is very crucial, because once they have finished their postgraduate studies, they really need to have additional funding for the first few years until they can get their own independent grants.
You are right. And actually, I'm sorry I skipped the one important slide. But actually, when we think about the development of the orphan drug, there is also the death barrier. And AMED provided, it's not huge money, but we are choosing almost 15 or 20 venture companies which are interested in the development of the orphan drug for rare diseases specifically. And this type of support in the Death Valley, AMED is very keen to increase. Yes.
And then my question is, what is your perspective on neuroscience research and how that fits into AMED?
I'm sorry.
Neuroscience, neurology, neurosurgery,
Okay.
research.
The reason why I chose the rare disease rather than other common disease, there is a reason. First of all, as you can know, the community, the medical community of the clinical genetics or rare diseases, they are very peaceful and always thinking about the patients and easy to negotiate. But if you go to the cancer research, for example, that might be very difficult. And the community is huge, and they are very aggressive. So we would like to open up the very small pore in the rare diseases, first of all. And accordingly, this area include the neural rare diseases. Almost 40% of the all diseases are neuron. So we are very much interested in supporting these patients. Yeah, that's why we chose this area.
Thank you very much for providing us with the insight. There's a fair amount of focus on orphan drug development. Are there opportunities as well on the medical device side? And are you looking at addressing some of the valley of death in that area if it actually exists in Japan?
Oh, actually, I'm sorry. That you are asking the story of the orphan drug and.
No, I'm referring to
let
medical
me have
devices. Like in Canada, we separate out approval and reimbursement for drugs from that of medical devices. So there are two different kinds of processes that are involved in introducing medical technologies versus orphan drugs. And so I'm wondering whether there's attention being given in Japan to the medical device stream.
Oh, yeah, of course. Actually, that is a very interesting question. So we are supporting the very initial period, initial processes of the orphan drug development, and also we have the very similar system for the medical devices. And in case of medical devices, if we use the National Clinical Database, which includes all the surgical intervention or catheter intervention, hopefully we can reduce the size and the number of patients to decrease the cost for each individual clinical research, because we can make a very good matching of the surgeon data in order to match the quality of this surgical operation. There is a huge variation of the surgeons. So if you choose randomly, you can get a very huge standard deviation. But in Japan, I think this is one of the big advantages in our country to choose very carefully and use a smaller number of the patients and the surgeons to check if the new devices are okay or not. That's what we are thinking about.
Dr. Matsumo, thank you very much. It was a great, wonderful talk. We're trying to do a lot of things around data sharing, and I think that there's a lot of people in this room that are trying to reduce the barriers that you had mentioned. And in fact, we actually have a hospital in the city that's called the Death Star. So,
okay.
So we have Darth Vaders in Alberta too. My question is around your genomic medicine, and I'm interested to hear about what your biobank strategy is for Japan.
Bio what?
Biobank.
Oh, yeah. Thank you for question. As you know, after the earthquake, the government decided to make up a huge biobank in Tohoku University. Now it is working, and they are establishing, just let me say one example. This is very useful. They are covering almost 3,800 Japanese people, not only in the Tohoku district, but also the rest of Japan. That gives us a very strong data for what is normal subject in Japanese people. And using this genome data, it becomes very effective to reduce the number of the candidate gene for the single gene analysis. And also, hopefully, 5 years later or 10 years later, we can see the natural time history of how the people are affected by the diabetes or other complications. That requires a long time to get the outcome. But the immediate effect of a biobank system is the application of their data, normal data, to the rare disease and undiagnosed disease. That's what we are expecting to have.
Thank you very much. Please join me in thanking Dr. Suematsu.
Thank you.